Good afternoon, everyone, and welcome to today's policy forum, Breaking the Cycle, Behavioral Health and the Path to Justice Reform. My name is Jana Wright, and I'm the Director of Policy at Insure the Uninsured Project, but better known as ITUP. We're thrilled to have you join us today for what promises to be an enlightening and impactful discussion. Please take a moment to introduce yourself in the chat with your name and organization. And we want to be sure to shout out our generous sponsor, Sierra Health Foundation, for their support. But before we dig into today's topic, I want to go over a few housekeeping reminders. So the first is this session is going to be recorded. The meetings, links, and resources will be emailed to participants and posted to the ITUP website after the meeting. Closed captioning is available. To enable captions, select the CC or transcript icon from your toolbar. Submit your questions at any time during today's webinar during the Q&A using the Q&A function on your screen, Chat is open and we encourage you to engage throughout today's discussion. So our next slide, please. As our name implies, ITUP was launched nearly 30 years ago in response to the high rate of the uninsured in California through policy reforms such as the Affordable Care Act and the expansion of Medi-Cal for undocumented Californians. We've seen the uninsured rate significantly decrease. Today, ITUP's focus is on bridging the gap from coverage to access. We understand that it is one thing to have a plastic insurance card in the wallet of yours, but it is entirely another to access equitable care. In addition to policy analysis, ITUP convenes regional stakeholders through opportunities such as our regional equity collaboratives and amplifies community voices to our partners in Sacramento in order to shape policy. ITUP is uniquely positioned to keep a pulse on what's happening in our communities while holding a macro level perspective of what is happening statewide. Next slide. As many of you know, equitable access to behavioral health services is essential for ensuring the well-being of all Californians, but this is particularly urgent for our justice-involved community who face a disproportionately high prevalence of mental health challenges. The link between incarceration and mental illness creates a damaging cycle, worsening health outcomes and deepening existing disparities. Today, our conversation will focus on this critical intersection and discuss how we can work together to disrupt the cycle and improve health outcomes for this vulnerable population. And if you haven't visited ITUP's website in a while, I highly encourage you to do so. There, you will find our latest Justice Involved fact sheet, our toolkits, and our coverage fact sheet series, as well as our legislation roundup blog. Over the next hour and a half, we will delve into California's efforts to integrate behavioral health within our prison and jail systems, highlighting both the challenges we face and the innovative solutions emerging from our communities. We'll receive updates on trauma-informed approaches being implemented, as well as insights into how the CalAIM initiative is impacting justice-involved communities and individuals. This forum is not just about sharing information, though. It is about fostering dialogue and collaboration. We encourage you to engage with our expert panelists as they share their experiences and insights. Your participation today is vital to the work toward solutions that promote help, justice, and equity for all Californians. Thank you for being here, and let's get started. So before we begin our panel discussion, our amazing graduate intern, Samara, is going to be walking us through some of the highlights of her latest fact sheet published, Transforming Behavioral Health Services in California Jail Systems. Samara, please take it away.
Thank you so much, Jana, and hello, everyone, and thank you for joining us. My name is Samara Akbarzada, and I have been privileged to serve as an ITUP health policy intern since January. I'm so excited to share my research with you today on a topic that's very close to my heart. So the title of my publication for ITUP is Transforming Behavioral Health Services in California Jail Systems, which examines the gaps in behavioral health services within California's jail system and highlights the urgent need for improvements in mental health care. I'll discuss some pioneering initiatives that California has already undertaken, as well as key policy recommendations. So today, I want to highlight the urgent need for equitable access to behavioral health services for California's justice-involved population, which experiences a high prevalence of mental health issues. Untreated conditions often worsen during incarceration, creating a damaging cycle. California's CalAIM initiative tackles this challenge through the Justice Involved initiative, which aims to meet the health and social needs of justice-involved Medi-Cal members. So by ensuring equitable access to mental health support, we can promote recovery and successful community reintegration. Now, California's justice-involved population faces numerous disparities. This diverse group includes individuals from various backgrounds and socioeconomic statuses who have interacted with the criminal justice system through arrest, detention, or parole. Many face systemic challenges like poverty, living in unsafe neighborhoods, and being exposed to violence in the community as children, contributing to their involvement with law enforcement. Additionally, substance use disorders and past trauma further complicate and worsen their health outcomes. Latinx and Black Californians are overrepresented in our jails, not due to higher crime rates, but because of racial bias in policing, unequal access to legal resources, and state-sanctioned anti-Black racism. This disproportionate confinement highlights urgent and deep-rooted issues within our justice system. So here in California, on any given day, around 60,000 individuals are held in jails, with 25% facing serious mental illnesses and 70% struggling with substance use disorders. Alarmingly, 60% are awaiting trial, and many cannot afford bail. Many also reoffend within 3 years of release, and individuals not yet convicted typically stay about 30 days. Additionally, over 120,000 individuals are incarcerated in state prisons. California annually invests approximately $1.5 billion in county jails. These statistics underscore the urgent need for reform in our criminal justice system. So while conducting research, I found significant variations between the differences of jails and prisons. In this fact sheet, we include a graphic similar to the one on this slide outlining the differences. Prisons are long-term facilities for individuals serving sentences longer than 1 year and are operated by state or federal governments. State prisons accommodate those convicted of felonies and offer programs such as vocational training and education to support rehabilitation and reintegration into society. In contrast, jails are short-term facilities for individuals awaiting trial or serving sentences of less than 1 year for misdemeanors. They're typically run by county or local governments. With limited programs due to brief stays, jails focus on temporary confinement and managing the local inmate population. Understanding these distinctions is essential for addressing challenges in our criminal justice system. Individuals entering jails often face serious mental health and substance use challenges that can worsen due to poverty, homelessness, and limited healthcare access. Incarceration heightens the risk of mental health decline from stress and isolation, while jails typically offer inadequate care. This illustrates a failure of the system. Untreated mental illness leads to incarceration where healing is never attained, perpetuating a destructive cycle. Generational trauma further compounds this issue, highlighting the deep failure of the system once again. Additionally, Latinx and Black students are disproportionately targeted for disciplinary actions and are more likely to be referred to law enforcement for minor offenses, worsening systemic inequalities. So as we consider innovative solutions, I want to highlight a few state-led initiatives here in California, such as the JI Initiative, the Community Assistant Recovery and Empowerment Act, or the CARE Court, and the Medication Assisted Treatment in Jails and Drug Courts Initiative. So the Justice Involved initiative within CalAIM aims to improve healthcare access for individuals in the criminal justice system by integrating physical and behavioral health services. This initiative seeks to reduce repeat offenses and enhance health outcomes through collaboration among healthcare workers, justice agencies, and community organizations. The Care Court program redirects nonviolent offenders with substance use disorders to treatment instead of incarceration. Care Court utilizes a monitored plan with counseling and drug testing to promote recovery and reduce reoffending, and aims to support over 2,000 individuals by the end of this year. The MAT initiative expands access in county jails and drug courts for individuals with substance use disorders, focusing on at least 2 FDA-approved medications. Participating counties receive ongoing support through coaching and training sessions, making this approach essential for effective treatment in our justice system. And for more information on these programs, please check out ITEP's fact sheet with all the hyperlinks and details. So rounding out in typical ITEP fashion, our publications wouldn't be finalized if we didn't include policy recommendations. There's been historic progress made so far, but there's always opportunities to continue the advancement of equitable healthcare access, especially for our justice-involved Californians. So here on this slide, I've listed the key policy recommendations to enhance mental health services. But please be sure to check out more details in the fact sheet. So first, increase state funding to improve resources, staffing, and training. Establish coordinated care programs for mental health and substance use disorders, incorporating peer support and rehabilitation. Implement screening protocols for early identification and timely interventions, including crisis response teams. Strengthen collaboration with community providers for continuity of care upon release, supported by data systems to track outcomes, and regularly review and revise mental health policies to align with best practices. In conclusion, I want to emphasize the importance of humanizing those who are incarcerated. It allows us to see their stories, understand their pain, and recognize their humanity. Many face challenges that stem from trauma, poverty, or mental health issues, circumstances that could affect anyone. By extending compassion and understanding, we create pathways for healing and reintegration into our communities. So thank you so much for listening, and please be sure to sign up for ITEP's weekly newspapers for all upcoming ITEP events and publications. And if you have any additional questions, please feel free to reach out to me or any ITEP staff. Our emails will be in the chat. Now it's my pleasure to pass it on to FD Sharoni to lead the next panel with our amazing panelists. FD, take it away.
Good afternoon, everybody. I'm so honored and humbled to be here at this really important event. It's very exciting to me that this topic, which has driven my now 25-year career, is really being opened up and discussed and really cared for in the larger healthcare arena and just community as a whole. I have worked on this issue, mainly focusing on youth involved in our criminal justice system, but really on everybody for, like I said, for 25 years. But I've worked on this issue from all sides. I started in a community-based organization. I've worked at law schools, with the defense, with prosecution, and ultimately, throughout all this time, my biggest lesson and what I really speak to is that trauma is really at the center of this, and that we need to heal trauma in order to move forward as a community. I have been able to work on these issues at the state level, at the county level here in Los Angeles, and also at the city level, where I was formerly the director of the Office of Reentry. I really, really believe that real community safety and health is only possible if we heal and respect and really honor everybody's experiences. We have a phenomenal panel today with great people who are doing the really difficult work, and I am going to introduce them. We can start with Ted-Min Chung, who is working at Amity Foundation. And Ted, would you like to introduce yourself?
Absolutely. Absolutely. So my name is Ted-Min Chung. I'm the Senior Clinical Director at Amity Foundation. If you guys haven't heard of Amity, we've been around since the 80s. We work exclusively with working with the reentry population. We have like 20 different programs spread out throughout LA and in Arizona that again only caters to the reentry population. All of our founders and people that are in leadership positions are people that themselves have gone through incarceration, been unhoused, gone through mental illness, or in recovery themselves. About half my team here, the program that I run through the Office of Diversion and Reentry, are people that themselves have had lived experiences. Amity, we do things a little bit differently because of our values and our missions and how we were created. So we use a lot of different terms. Our interactions tend to be different when we work with our students. That's what we call clients here, because we consider ourselves a faculty or campus of learning. We don't use the, like I said, we don't use the word client, we say students. We don't even use the word case managers. We use advocate. One of the main reasons why we're a little bit different is our campuses, or the way that we connect people to services, because our whole mission is we are trying to reverse how mass incarceration is a solution right now, unfortunately, to homelessness and substance use and mental illness. And the way that we are trying to do that at Amity is really to see some of our students as peoples, you know. So when we start in the jails, we start developing these connections, preparing them for release. We go from in prison to release to community. They come out directly into our campuses. Again, we have 20 different programs, so we have a lot of different ways in which we try to work with the reentry population. But once they get to our campuses, it's a whole entirely different environment, and that's for us is really important, is to be able to develop that supportive network and environment for our students to turn things around. So we have clinics here that's on campus where they can get directly connected to medical services. We have psychiatrists here. We have parole offices here on campus. We have programs for many of our students here. So we basically do all the necessary things to prevent someone from falling through the cracks. We're there day one because many of us have gone through a journey and a process, and when we pick them up directly out of custody at release, we're saying we've gone through a journey. Now we're going to help you through your process and journey as well. And then again, we do that in many different ways. Again, we have a lot of different day class programs. When they come out to our campuses, their schedules are packed. We have so many different mental health clinics and medical clinics that we can connect them to. We help them with the benefits right away. Because if you think about it, we're all of our reentry population, they've gone through decades and decades of trauma and negative coping skills, and they need the extra help in which to help navigate the healthcare system, help them navigate through the mental health system, how to access benefits. I mean, me myself, it's hard enough for me to navigate my insurance and my benefits, you know, and my medical, you know, concerns and issues, you know. So our reentry folks need as much help as possible. So if you were to describe this as, if you see a student in the middle of a circle, they're surrounded by all these different partner agencies: probation, parole, psychiatry, PCP, court system, job development. We're right next to the person in that middle of that circle, connecting all those circles, making all those linkages, so that we're creating a safe, supportive network. So that means our folks don't fall through the cracks. So I probably talked enough already. That's a little bit about Amity and who we are. I'm gonna pass it on to the next panelist.
Thank you. Amity is a great, amazing program. So we understand your eagerness to tell us all about it, and we're going to learn a lot more about it as the process continues. Mia Cooper-Kahn is with us as well. And would you like to introduce yourself and tell us a little bit about your organization?
Yeah, thank you so much. Hi, everyone. My name is Mia Cooper-Kahn. I am the Senior Manager of Behavioral Health at Community Health Center Network and Alameda Health Consortium. We're the network of 8 federally qualified health centers in the East Bay area. And in my role, I support the integrated behavioral health programs at our 8 member health centers. All 8 of our health centers have what's called the integrated behavioral health model, where behavioral health services are integrated into primary care. And for those who are familiar with the behavioral health policy landscape, all of our health centers serve the mild to moderate behavioral health patient population, and some of our health centers have specialty mental health contracts with the county to provide that higher level of care. Collectively, our health centers provide, in 2022, we provided 128,000 behavioral health visits, with 37% of those being virtual. And I brought to this panel because I was a member of Alameda County's Care First Jails Last Task Force. And as a representative of Alameda Health Consortium, I really was a part of that space, coming from the angle that a strong preventative behavioral health system is essential for keeping people with SMI out of hospitals and jails. So as a member of this countywide Care First Jails Last Task Force in Alameda County, which just came to a close a few months ago after a 2-year period, the task force's role was to develop a set of recommendations to reduce the number of people with SMI in our local jail, in Santa Rita Jail. So after many, many months, 2 years of work, the task force created a list of 58 recommendations that essentially laid out a plan to reduce the number of folks in the jail with SMI. The task force had representation from 8 county agencies, including the Behavioral Health Department, District Attorney's Office, Department of Housing and Community Development, Probation, Public Defender, Sheriff, Social Services, to name a few of them. And I was a representative as a city county contracted agency. And essentially, the kind of message I want to bring to this panel is how essential it is to have a strong preventative mental health system in the community, in order to, as part of a strategy for prevention and early intervention, to keep people with mental illness out of the jail, and the importance of investing in community-based solutions for mental illness. Thank you.
Thank you so much. And lastly, we're going to have Megan Shandell introduce herself and tell us a little bit about where she's coming from.
Hello, everybody. My name is Megan Shandell. I'm the Chief of the Policy and Program Support Unit, working on the CalAIM Justice Involved Reentry Initiative for the Department of Healthcare Services, Office of Strategic Partnerships. My branch is responsible for the policy development and stakeholder engagement for the CalAIM Justice Involved Reentry Initiative. This initiative supports justice-involved individuals that are housed in county correctional facilities, youth correctional facilities, and state prisons by providing key services pre-release, enrolling them in Medi-Cal coverage, and connecting them with behavioral health, social services, and other providers that can support their reentry. I'm pretty passionate about this project. I've been here for about the last year and a half, but I came in with almost 14 years of experience from the Department of Corrections and Rehabilitation, where I implemented several key programs and supported many others. but I got to witness firsthand that side of the coin that provides services and that is just under-resourced. And so I'm excited to be on this project and to get this program off the ground to provide the additional resources, but more importantly, the linkages to post-release care.
Thank you. I'm really glad that we were able to start our session with a very thorough behavioral fact sheet. And for me, as a director of reentry, a really big issue was really explaining that there's so many different types of populations within the reentry community, you know, and the needs of, let's say, some of the lifers that maybe Ted's organization, Amity, would be working with would be different. And so I was really hoping maybe we could start with Megan because she has, you know, such a vast experience. If she could maybe tell us about some of the innovative solutions that you guys are working on within the different populations, because I know you're working stuff with youth and everybody different. So it'd be great if you could talk about that. And we'll start with there and then everybody else can sort of jump in after.
Sure. Shirley, if you could pull up that puzzle piece slide, we have found that a visual helps walk us through the mass components of the Justice Involved Reentry Initiative. This is a massive program, not just for the counties, but for the state as well. And so we'll just walk through some of the components of the program. So like I said, this initiative supports justice-involved individuals that are housed in the county correctional facilities, youth correctional facilities, and state prisons, but by providing key services pre-release, enrolling them in coverage, connecting them with behavioral health, social services, and other providers that can support their reentry. Our demonstration's goal is to build a bridge to community-based care for justice-involved Medi-Cal members by offering them services up to 90 days prior to their release to stabilize their health conditions and establish a plan for their community-based care. The key components of this initiative are the pre-release Medi-Cal application processes. Those went live, I believe, back in January of 2023. The 90 days services pre-release, those began to go live in October of this year, and I'll touch more on our timeline in a little bit. Behavioral health links, enhanced care management, community supports, and then the justice, reentry, and transition providers. So we hope that by establishing relationships between community-based Medi-Cal providers and the justice-involved populations prior to the incarcerated individual's release, that California can improve the chances that individuals with a history of substance use, mental illness, and/or chronic disease will receive stable and continuous care. Shirley, if you can move to the next slide on eligibility. We'll just touch on the different eligibility criteria for the program. So to be considered eligible for pre-release services, incarcerated individuals must meet the following criteria. They must be a part of a Medi-Cal or CHIP eligibility group. So the individuals must meet all other income, immigration, citizenship, and household composition eligibility criteria. Individuals will be eligible for pre-release services if they otherwise meet requirements for an eligibility group, regardless of whether the group is funded through state dollars only. Medi-Cal eligibility groups include new adults, parent caretaker relatives, youth under 19, pregnant or postpartum individuals, aged, blind, or disabled individuals, children or youths currently in foster care, and former foster care youths up to age 26. CHIP eligibility groups include youth under 21. So again, Medi-Cal eligible classifications and groups are pregnant and postpartum individuals. And then just a special note that all youth under the age of 21 and former foster youth between 18 and 26 years of age do not need to demonstrate a healthcare need to qualify for the pre-release services. You just have to be a member that falls into the Medi-Cal or CHIP eligibility groups, and either a youth in custody, no healthcare criteria needed, or an adult that meets one or more of the healthcare needs criteria. So if Shirley could move us to the covered services slide, we'll touch on those real quick. The pre-release services authorized under the Justice Involved Initiative include the following services currently covered under DHCS's Medicaid and CHIP state plans. And those are reentry case management services, physical and behavioral health clinical consultation services. Those could be provided through telehealth or in person as needed. Those services would be to diagnose health conditions, provide treatment as appropriate, and support the pre-release case managers' development of a post-release treatment plan and discharge planning. Laboratory and radiology services, medications and medication administration, medication-assisted treatment or MAT for all Food and Drug Administration approved medications, including coverage for counseling, and services provided by community health workers with lived experience. So just again, we painted a very broad group of eligibility criteria. The healthcare needs criteria is found within our policy guide, which I believe Shirley has the link to. She can drop that into the chat as well. And then these are the targeted pre-release services that will be provided in the 90 days before somebody is releasing to their community. And so once a release date has been identified, individuals that screen positive for behavioral health needs, including substance use disorder needs, will receive a behavioral health link to their post-release behavioral health provider. During that behavioral health link, the individual will also be scheduled for their post-release follow-up appointments within a clinically appropriate timeframe. If they have a need for transportation to their post-release appointments, the pre-release care manager will work with the individual's managed care plan for them to utilize the transportation benefit also. Additionally, at the time of release, individuals will receive a full supply of their medications in hand. So the timeline that I referenced earlier, county behavioral health agencies went live on October 1st with the ability to receive a behavioral health link from any correctional facility in the state that has been approved to go live with pre-release services. All correctional facilities will be required to demonstrate readiness to participate in the Justice Involved initiative prior to going live with pre-release services, and then DHCS will require each individual correctional facility to complete a readiness assessment and receive our approval prior to that go live date. So correctional facilities may go live as early as October 1st of this year, dependent on the DHCS approval of their readiness assessment, and they must go live no later than October 1st of 2026. I'm happy to report that as of today, correctional facilities located in Santa Clara and Yuba counties have gone live with the pre-release services and are implementing all facets of the program. And I'll pass to the next person.
Yeah, Mia, I was really interested. You were talking about the needs for primary medical health care for people upon release, and just some of the really important work, really client-centered, starting where they're at. So I was hoping that you could talk about some of the innovative things that you and your organization have been working on.
Yeah, absolutely. Thank you so much. And it's helpful to get the statewide overview and then kind of hone in on the local and what's happening at the kind of local level. So as I mentioned, all of our health centers have integrated behavioral health programs integrated into the primary care clinics. And I really want to kind of uphold the narrative that health centers and federally qualified health centers are such an important part in terms of prevention and early intervention. And a couple of our member health centers also do have reentry programs that are part of the Transitions Clinic network as well. But essentially, I really want to kind of hammer the point that all of our FQs are continually struggling when it comes to supporting and creating a robust behavioral health workforce. It's really difficult in FQs to recruit and retain behavioral health providers that can provide that preventative care in the community. There's also been some discussion around implementing kind of low barrier services when it comes to substance use disorders in community health centers, and reducing the barriers to access to services like medication assisted treatment. I also wanted to highlight some special programs that our health centers have, including one of our health centers, Access Community Health, has a very an incredible mental health urgent care program, essentially that where folks can walk in during business hours for if they are in crisis or need additional support. We're definitely looking to support and scale that program as well. So yeah, those are a range of some of the programs, in addition to that integrated behavioral health model that we're always looking to uphold and support across our FQHCs that really make up that kind of prevention, early intervention spectrum of services in the community.
Thank you. Ted, I've had the privilege and honor of spending a lot of time at the Amity Foundation, and I think that you guys have a very unique, holistic approach. And in terms of the healthcare, I think it's phenomenal that they just have to walk across the street at Amistad, and there's a clinic right there. And so maybe you could talk a little bit about any other innovative solutions, or how holistic health, beyond just being able to have the medical clinic, is really serving our population.
Yeah, definitely. We have a lot of different programs here that really caters to a lot of different issues and details that's revolved around the reentry population. We have one of our key things is we want to develop that really sense of community for our folks. We consider ourselves a therapeutic community, and what that means is we have this: when people get out, they're not just by themselves. They're welcome to our community. The first thing they entered is we have a beautiful facility with homegrown fruit and vegetables. We have fishes and things like that. But they're welcome into a sense of community, because what often happens is when reentry folks are released, is they're released with a paper of resources, and basically just no one to really help them through all the different things that they need to basically set them up for success, right? So many of them may get rearrested and so forth. So we have that sense of community, and we have counselors, we have demonstrators. Again, both demonstrators and counselors are people that themselves have lived experiences. So we sense that sense of the community, so that they are not doing this basically by themselves, right? Because again, if we are asking people to not engage in negative coping skills, or be part of communities that had previously failed them or were beneficial to them, that's going to take a very long time to change, right? Because we're asking people to change decades and decades of negative coping skills, of losing attachments, losing relationships. We have to help them create this new sense of community, new sense of coping skills. So we do that in many different ways. Again, we have daily programs for our folks, so that they go to different support groups. As you mentioned, we have different medical facilities that they can get to. The two biggest things that we also help address is the mental illness and the substance use, right? Because about 99% of our folks, at least in the program I work with, are co-occurring. Some of our folks are some of the most severe mental health populations in LA County. We call them the 5%ers. They use 5% of the most resources in LA due to hospitalization and incarcerations. So there's two main things that we do. We help them connect them to a lot of different services. Again, we have psychiatrists here on board. We have connections with different drug companies where they give us samples for injections and things like that. Because as you know, many of our folks who come out of custody now, they have no insurance. They got to get their Medi-Cal reinstated, and that can be a hurdle. That can take months in advance. Whereas when they were stable in jail because of the injections, they come out, they got no injection because they're not connected to Medi-Cal. So we have connections with different pharmaceutical companies. We have, again, our psychiatrists. We can get them on different medications like Vivitrol. And then we also have connections with other drug substance abuse programs such as the NAT and contingency management programs as well. So if we're talking about holistic approach, we basically seeing them for where they're at and basically what they need. And we just try to surround them with so many different resources. So we just basically whatever they need. We just don't just focus on the mental health and substance use. We focus on the employment side, on the family side, how we unify some of the family members for our students. So we do all different facets, if that makes sense.
Thank you. So, being that we are so close to the election, you know, 224 has been your behavioral health ballot propositions. Earlier this year, voters passed Proposition 1, which reshuffled behavioral health dollars from a focus on prevention and early intervention activities to our unhoused populations. In November, our voters will be facing the decision on Prop 36, which will be rolling back major parts of Prop 47. I'm not sure how familiar everybody is, but Prop 47 was passed by voters in 2014, and it reduced the threshold on some felonies, it actually raised the financial limit for some to become a felony and changed some other felonies to misdemeanors, thus reducing our prison population. And also the most important part to me is that it funneled money that was used to over-incarcerate our state into the community, mainly into these trauma recovery centers, which were for victims of crime, and also into a lot of reentry services and providing a lot of funding into all the great work that we're hearing about today. And I know I was hoping that maybe Ted and Mia could touch on a little bit on how they think if Prop 36 passes, how that will affect our communities, and if anybody has any other thoughts around Proposition 1 as well. Thanks.
I'll let Ted speak to Proposition 36, but I wanted to touch on what you mentioned in the very beginning of your remarks around Proposition 1, which passed in the March ballot. And essentially, as you said, the Prop 1 is reshuffling how counties can spend their Mental Health Services Act dollars under the Behavioral Health Services Act. And as you mentioned, we're seeing in the policy money being pulled away from prevention, early intervention towards homelessness and housing, which of course is an incredibly important issue that we need to put funding towards. But unfortunately, they're seeing that at the expense of prevention, early intervention programs that, as I was mentioning earlier, can really prevent and provide that necessary infrastructure to prevent unnecessary hospitalization and incarceration. So our health centers in Alameda County are certainly following as the state comes out with more detailed guidance around the BHSA and really looking to look for sustainable funding for all the prevention, early intervention programs that were and have been for a long time funded under MHSA, including a lot of our culturally and linguistically tailored community-based prevention behavioral health programs, community health workers, care coordinators who are really doing the connective work, connecting folks from, the health center to wraparound services to social determinant resources across the county. The impact of the Proposition 1 is robust, and we just want to make sure that we're continuing to fund these prevention and early intervention behavioral health community-based programs in the communities where people are being served.
Yeah, in terms of Prop 36, it feels like we're kind of going backwards, with that, because we tried that, we tried mass incarceration before as a solution for homelessness and substance use and mental illness, and that just basically flooded our county systems and our prisons and jails, and it feels like it's just we're putting a Band-Aid on some of those issues without trying to solve the core issue of what's going behind those issues. Our belief is that people are much better served and receive much better treatment out in the community rather than in custody. In custody, they won't get as much trauma-informed care, they won't have much resources, won't have much focus and attention as they will out in the community under the right programs. Our philosophy is that our folks, our reentry folks, if we want to truly prevent further recidivism and rearrest, we need to go to the core of the issue, which is mental illness and substance use, and we need to be able to fund and those programs and put focus on those programs, so that we can help reduce some of the numbers for homelessness and substance use and ODs. I get the reasoning behind this proposition because fentanyl is a very scary drug. And I think the scare for fentanyl was what really propelling this proposition, because they want to reduce people in the streets and sales and things like that. But I feel like there just needs to be a better way in order to do that. And I believe that solution is more focused on funding community-based services.
Thank you. Both of you guys touched on such an important thing, which is really prevention, right? And so, in my many years, I will say that, when I was working with juvenile lifers in CDCR, which are all youth, they were all adults at that time, but they were all youth when they committed what is known as their life crime. It was never a question of, have you witnessed a murder or have you lost a loved one? It was always how many. And in the population in general, I would say that everybody was around 12 or 13 people that they had lost to gun violence and different traumatic events. And so I really, really think that, what Mia was talking about, prevention and really starting early, that's the real answer to violence prevention, right? Is treating the traumas in our community before, it gets to the point of, Father G has my father, Greg Boyle from Homeboy Industries, says, hurt people, right? And it is so true. And it is a very simple saying, but I think it's important for all of us to remember. And so if we're not helping, then, like the help that is offered at the trauma recovery centers to people who are victims of crime, then it's going to end up going out somewhere else. And so on that note, I would love to ask if the three panelists have any takeaway messages for policymakers in Sacramento, and just, anybody in our audience that you think has an important message for people to really understand from all of your really intimate work with this population.
I guess I can start. I think something that Mia kind of touched on is how do we develop our workforce that wants to work with the reentry population? I'm sure I'm not the only supervisor or clinical director here that's having a very hard time finding clinicians, licensed clinicians in order to work with the reentry population. A lot of social workers, they do tend to want to work with kids or older adults, but we don't. But it takes a very special someone to want to work with reentries. Right now at Amity, we're really connecting with a lot of our local schools and universities, such as USC, UCLA, a lot of Cal States, in order to develop our MSW internship program so that we can train people to want to work with reentry, because many folks are very scared when they hear reentry, they hear severe persistent mental illness and substance use, they get scared about working in that population. So what we've been working on is really developing that workforce so that we can do prevention, early prevention, so that we can work with post-release and things like that. So that's something that we're working on. If in terms of policy, if there's some type of incentive or some type of way that we can connect a lot of CEOs to the schools and so forth to develop that workforce. Because what's also been happening is a lot of people that work with reentry are people that themselves have lived experiences, and they themselves have barriers to further their education. Some of our MSW interns themselves have difficulties finding placement, internship placement because of their background. Because some CBOs won't take any interns with their background. So these are some of the things here, at least with AMI, that we're really trying to change.
Thank you. Yeah, I would say, in a nutshell, to consider federally qualified health centers as part of the realm of preventing, I feel like I sound like a broken record here on this panel, but prevention and early intervention services in the community. And there's still a number of barriers that FQHCs face in terms of providing that robust those robust prevention services, including things like securing same-day billing. So FQHCs cannot currently bill for a physical health visit and a mental health visit on the same day, which is completely antithetical to the integrated behavioral health model. And of course, the behavioral health workforce challenges that so many of our health centers and CBOs face. I didn't get to go into them in detail, but I just wanted to point to, I mentioned earlier, the 58 recommendations at the county level that the Alameda County Care First Jails Last Task Force came up with. And I think Shirley shared those in the chat. So I just wanted to plug for folks to take a look at those and look at them for yourself.
I am a policymaker in Sacramento, so I'm in listening mode right now. But just wanted to express that it's not AI or a bunch of bots writing policy. There are some very bright and passionate people behind writing policy right now, especially for the Justice Involved initiative. I work with a fantastic group of passionate, driven people who really want to see change in this space. So be comforted by that at least, and that we're working really hard, just as you guys are.
Thank you all. I think I see that we have a few questions from the audience. If anybody else has questions, please feel free to put them in the chat so we can get to them. Sorry, let me just scroll and find. Okay. We have a question about how this works in jail settings, where the release date is often unknown or subject to change. Obviously, in prison, it's generally more predictable in terms of release date, and we have advanced warning, but in jail, it's more chaotic. So I'm not sure, maybe Megan, or I'm not sure who would be the right person, or if you have any ideas on how this could work.
I'll jump in. I think it came up during the part that I was talking about our Cal-AIM Justice Involved initiative. So we at DHCS are well aware of the fluid situation that a release date can be at a county correctional facility. Like FT said, prisons are a bit more predictable. And so we have developed what we're calling the short-term model, which is guidance for county correctional facilities and how to implement this program, how to get an individual connected to these post-release services on such a very short time frame. And so that is within our policy and operations guide that I believe Shirley linked above in the chat. It would take a long time to cover that in detail for this discussion, but I would encourage you to look at that because it does provide guidance and direction on how to make the connection to post-release providers, and then how to even go about if the individual released and you weren't able to make the connection just yet, how to close the loop on that as well.
Do Ted or Mia, do you have anything to share about that, or should we can move on to the next question? This is a very a great question. I love this one. The question is, and I might add a little to it. Have you found that individuals recently released from incarceration experience stigma or discrimination from treatment providers in the community? Wondering if health records are sent from the carceral setting might put them at risk for inequity in care. I would also just like to add, I don't know if anybody has ideas, but it's also, when we're talking about trauma, there's an incredible amount of trauma that happens in the facilities while people are incarcerated, and they develop protective factors to help them, and it helps them survive prison or juvenile hall or the county jail. But those sort of mannerisms or body language can be viewed disfavorably by other people. And so I would love to, if you guys have answers to that, but for everybody here to really think about how they're making their healthcare services being cognizant of everybody's trauma who's walking in, and how you can provide a space that will allow them a way to feel more comfortable and also to be seen.
Yeah, I think I can talk about that first. We understand what the stigma and kind of there's a lot of mental health stigma with a lot of our reentry folks, and we get that, and they might engage in some self-preservation skills, as you mentioned. We get cussed at all the time, to see if we would leave, and some people are very protective about the way that they talk about their trauma, and they talk about their families and things like that. So there are different ways that we help train our staff to really recognize those signs. And our biggest thing is just keep showing up, because a lot of the times a lot of our folks, they've been abandoned at multiple points in their lives, right? So if we're gonna try to kind of break that cycle, then we just have to keep showing up to make sure that they're there, try to understand what their trauma is like. We try to teach our staff to use different words that are not so clinical, but make sense to whoever the person is that we're trying to treat. So instead of using words like, have you been depressed, recently, something like that, I'll say something like, how often do you feel tired? How much sleep did you get last night? Describe things in more anxious, things in more physical terms. Instead of saying, have you been anxious today? Have you had a panic attack? We'll ask things like, oh, how often do you worry about this? How often do you think about this? So we try to engage with those folks with terminology that feels a little more safe and a lot less basically poking them.
Yeah, actually, one of the recommendations that came out of the Care First Jails last task force in Alameda County was really improving robust collaboration and case management across all the various systems that folks are touching. And yeah, those recommendations really focused on general communication and collaboration across agencies and with the public. And targeting the designation of delegates to manage cross-agency communication and collaboration efforts. So, all that the stigma that you mentioned is there, but efforts to improve collaboration, coordination, case management, I think are really important in addressing that.
From a policy stance for DHCS's Justice Involved initiative, there is a data exchange requirement that is supposed to happen between the County Behavioral Health Agency and the correctional facility as part of that behavioral health link there to share treatment records. And so I think that's a little bit of where the question might have stemmed from. We are aware of any potential stigmas that this individual could face out in the community. And just to clarify, the policy intent is for the information to be exchanged from practitioner to practitioner. So if the concern is that protected health information would be mishandled and given to any custody type of classification. That's not the intent of the policy. And then we encourage each entity that's implementing the program to discuss any HIPAA questions or concerns with their legal team. And if they have questions, they can, of course, come to DHCS as well. Our inbox is open for those, and we have received those types of inquiries before, and so we have some answers readily available too.
Thank you. We have some other great questions that I think are really talking about the different needs between women and men, and the way they're different. They have different needs, mental health services. One of the questions is, how do the unique mental health needs of pregnant or parenting women in jails differ from those of male inmates, and how should those services be adapted? And also, what barriers do women face in accessing mental health services within jails compared to men, and how can these barriers be addressed? So whoever wants to jump in.
Part of Amity, and we work with the Office of Diversion and Entry. We do have an maternal health program specifically to address some of our clients that are going through pregnancy or postpartum. So we do have a program to address those needs, especially for people that are in custody, and then also releases as well. So we have a housing program for them specifically that many of our pregnant clients can live at, where they get the services that they need. And usually they do have a PCP there as well, so they can address their pregnancies and prenatals and things like that.
I'm going to defer to my colleagues on this one.
I was just searching through my inbox looking for something I saw this morning about some additional guidance that we are working to release for pregnant and postpartum individuals participating in the covered services of our program. So there is some additional guidance that will be coming out on that. And then, of course, Medi-Cal defines postpartum as 365 consecutive days following the end of the pregnancy. And so all those individuals would be eligible to receive the 90 days pre-release services under our program, and then to also be connected through a warm handoff for physical health services to their enhanced care management provider in the post-release setting. So
thank you. Yeah, those issues are very real. And I can't remember who was bringing up abandonment, but I'm not sure. I don't have the stats in front of me, but I do know that women in prison receive much, much less visits than men do, because generally it is the mothers, sisters, and wives and children who are coming to visit men. And there's a stigma against women that women are abandoned much more by their family. And I have been in visiting days at a women's facility and visiting days in a men's facility. And there's a line out the door, and there's often very few, if any, visitors for the women. So I really encourage all of you to really look at that issue and what we believe women are supposed to be like and what men are forgiven for, or different things like that, really play a role in how we treat our clients and our populations. We have another question here. How can we address the needs of inmates with co-occurring mental health disorders and substance use disorders, ensuring integrated treatment approaches?
I can start on this one. I think one of the first things that we look for is what's causing that behavior, what's causing that issue, because there's so many things that, like, if someone's having psychotic episodes, if someone's having hallucinations or delusions, do we know if that is something that's substance induced, if that's something medical? So we do a lot of assessments in terms of what is driving that behavior. Is it due to their mental illness? Is it due to their substance use? Is it due to a medical concern? Or is it just a personality thing that's causing to have that behavior? So after we have we are able to rule things out, then we find the appropriate intervention with it. If it is medical, okay, great. I mean, not great, but it'd be great that we can find an answer. Then we can connect them to the right medication services in psychiatry. If it's something that's more substance induced, then we want to go through the substance, residential programs route. If it's something that's more mixed, then obviously we're gonna target things at a multifaceted, manner. But it's important for us to, because it's such a complex issue for us to figure out what is the cause of that behavior. So me as a clinician, I always, and what I teach a lot of our other clinicians here is, it's always going to be a working diagnosis. Because again, sometimes we have psychiatry in jails that might see somebody just for 5 minutes, and then that's it. And they have a diagnosis that they carry with them for the rest of their lives. So for me, it's always a working diagnosis that we try to.
Our policy guide speaks to different screening procedures for substance use disorders and mental health illnesses. And so there is a section, and I'll drop the actual section link. There is a section that speaks to co-occurring diagnoses. And so the policy instruction is that to reduce, whenever feasible, to reduce unnecessary repetition of screening and assessments for individuals identified as having co-occurring diagnoses. We recommend that similar and standardized screening and assessment instruments should be used across the justice settings, and then we provide some example screening tools. We have not standardized a screening tool for this purpose as of yet, but we do have some examples that correctional facilities and behavioral health agencies can agree upon that will be utilized to hopefully help with this work.
Yeah. While I cannot speak to addressing co-occurring conditions for folks who are in the jail, I can speak to it in terms of in the community. And we definitely need continued investment in programs, treatment facilities, psychiatric treatment beds, programs that really address the needs of specifically the folks who are experiencing co-occurring mental health and substance use. So continued community-based investment in programs to support this population.
Thank you. We can move on to the next question. What specific outcomes or metrics are being used to assess the effectiveness of behavioral health programs in California's prisons and jails? How can we ensure transparency and accountability in reporting these outcomes? I hope that maybe Megan can, if you're going to answer this, if you have any questions, also include youth who are being held in juvenile halls and those types of correctional facilities as well.
I'll be honest, I was typing. Can you repeat the first part of the question at least? After you're muted.
That doesn't work, does it? What specific outcomes or metrics are being used to assess the effectiveness of behavioral health programs in California's prisons and jails and juvenile facilities? How can we ensure transparency and accountability in reporting these outcomes?
That is an awesome question, and one that we are working diligently to lift up. So we are currently developing oversight and monitoring metrics for the Justice Involved initiative, which will include some data points eventually on behavioral health agency implementation levels and also the correctional facility implementation activities. Unfortunately, I don't have a timeline on when we'll have those finalized or posted, but DHCS maintains like a data dashboard on our website, and the hope, which is still unapproved, but the hope is that we would have a space on that dashboard to report out the efficiency and, for the sake of transparency, the implementation status across different correctional facilities. As of right now, because it's so new and we just started correctional facility implementation this month and they have a 2-year window to go live, we have a dashboard on our Justice Involved webpage for DHCS that has the status of all the correctional facilities in the state. If they've submitted a readiness assessment yet, if that's under review, their targeted go live date. And so we encourage counties to view that, especially if they are local partners working towards implementing the same program and must collaborate together. That is a great dashboard to use for that. And so we'll link that. I don't know if Shirley has a link, but if she doesn't, I will link it in the chat as well for everybody.
Thank you. Are there direct, well, I know are there direct services, but hopefully you guys can talk about it. Direct services and resources for children and families of parents or parents experiencing incarceration, and how is their healthcare needs and how are they being addressed? Because incarceration doesn't affect only the individual, right? It has such a long-lasting effect on everybody else. So I was hoping you guys can speak about that a little.
At least for Amity, most of our work is press release, and most of our work is working with the individual clients. But once they are released into our facilities, finish their sentences or on parole, we do a lot of family reunifications, do a lot of family events and clinics so that they can come out to these events, so they can help reestablish these relationships. And that's at least what we do.
I really appreciate how this question highlights and emphasizes the impact that incarceration has and mental illness has on family members. I just wanted to point to a few of the recommendations. I know I'm not directly answering your question, but the recommendations that the Alameda County Care First Task Force really we really wanted to emphasize that impact on families and the importance of enhanced efforts to share information with community members and inform families and communities about the resources that are out there, including peer roles and alternatives to police involvement, etc. So just wanted to flag that that was the recognition that the supporting family members is kind of essential part of the solution to towards a care first in Jail's Last County.
At this time, our policy guide does not require the involvement of family members or identified support persons. However, the reentry care plan development is supposed to identify these potential support persons for the member, and they can be involved in the warm handoff process at the member's consent. So we left that open for the member to decide if they want them to participate, but we do see the value in that.
Thank you. And I think that for our last question, I was hoping that each of you could take a couple, or actually maybe we'll do another question really quickly. I think we have 10 more minutes, right? So let's do this one first. What are, if any, engagement opportunities that individuals and communities can partake in to continue working and improving behavioral health services within their communities to prepare for those in the JI population to successfully reintegrate?
I'll take a first stab at this one. I know our Medi-Cal managed care plans are looking to bolster their JI ECM provider networks. And so if you are eligible to be a JI ECM provider, I would encourage you to research that and connect with your managed care plans to do so. I know our county behavioral health agencies as a whole are very engaged in the Justice Involved initiative, very invested in the success of the initiative. And so I know they're on a local level working very closely with their local partners, local managed care plans, and correctional facilities as well.
Abdi, can you repeat the question? I think I
That was
kind
a
of
long
lost
question.
it.
You don't remember everything I said? Okay. What are, if any, engagement opportunities that individuals and communities can partake in to continue working and improving behavioral health services within their communities to prepare for those in the JI population to successfully reintegrate?
I would say in Alameda County, to continue following the work of the recommendations. We're at the point where the recommendations have been published and presented to our local Board of Supervisors, and it is through our local Mental Health Advisory Board that the recommendations are going to be monitored and implemented. And so there's plenty of opportunity for anyone to engage in that process and join the ad hoc committee that will be meeting monthly moving forward to move this work forward and working with our county agencies. So that yeah, that's all I'll say. Thanks.
Thanks.
At a kind of local CBO kind of level, our work is to try to really normalize seeking treatment and trying to tackle that sense of stigma and taboo in regards to seeking treatment. Seeking treatment such as mental health and substance use disorders. So for us is to have those difficult conversations, having that support network, saying, hey, I've gone through a process, I've gone through treatment, I have a therapist. That's why we have demonstrators here and counselors that themselves have gone through the same system and the same process. Again, most of our people in our leadership have gone through that process, so they understand what it's like. So when we're providing our direct services to people that's coming directly out of jail, we're able to say, hey, these are things that I've done. These are things that has helped me. I'm going to try to help you with these things too. So we're going to try to normalize some of that so it's not so stigmatized.
Yeah, peer navigators or whatever the different, there's lots of different terminology and names for it now, but those are, I think that they're phenomenal in helping people through the process. So I think that can kind of go into our last question. So it's our last opportunity to hear from this amazing panel. What steps can individuals take to educate themselves and their communities about the specific behavioral health challenges faced by incarcerated individuals?
I
think
think participating in policy discussions like this are great and very informative. Especially just personally, I've learned a lot from Mia and Tedman today about the work that you guys are doing in your spaces. And so I think just continuing to engage on this level, and then let your friends know, let your colleagues know these spaces are here and these discussions are being had. And it's very important that everyone engages if we want to really make change and make a difference.
Yeah, for us, it's my message is that it does take a community. I don't think one person can do it by themselves. They need a support network. They need a community in order to make these changes, and not only to make these changes, but make these changes last. So what can someone do to educate themselves, or what they can do to help is again be able to have those difficult conversations to normalize those conversations and seeking help, because many of our folks might be scared or hesitant to seek out that help through stigmatizations and taboos and things like that.
Yeah, I appreciate both of your comments. Megan, what you shared reminded me that, we really need to be coordinating the local and statewide efforts. And I echo your sentiments of having spaces to be able to be in the same room and hash out where the overlaps are so incredibly important. So we make sure we're taking advantage of all the opportunities that we have. And also, I was going to say, listening to families and individuals with lived experience, making sure that folks are in the room. And I have learned so much from the family groups like FASME and NAMI, Alameda County, and folks who have been part of the Care First Jails Last Task Force. So really, really kind of centering impacted folks in all conversations and discussions and policy.
Thank you. I love everybody's answers. This has been so informative and great. And if, there's so many takeaways, but I really believe that, what Mia was saying about listening and really centering those who are impacted and listening with an open heart. And sometimes listening to other things that they have to tell you before they get to what you need to know. So it's a good life lesson for us in all of our conversations and interacting with everybody. But I think that it's really important for us to move forward with open hearts and open ears and minds into this work. Thank you so much for joining us. And I'm going to pass it back over to you all.
Thank you so much, FD and Tedman and Megan and Mia. This has been such a delightful panel. I'm just really excited about this. Over the past month or so, we've been organizing this. So I knew it was going to be a great panel. I got so many wonderful quotes, which I'm sure will be uplifting in social media. But I want to go back to what you said, FD. It really boils down to hurt people, and how we are centering trauma, centering the individuals who are struggling with trauma and seeking trauma-informed approaches and all that we do for this population. But again, thank you to our wonderful panel for their time today and just sharing their experiences with us. I've got two final announcements before we end our time today. The first is that I would love for you all to join us on October 29th from 1:30 to 3 for our next policy forum. 2024 presidential election, what's at stake for health equity in California. We'll be digging into some of the ballot initiatives as well during this conversation, so it'll be a good one. Please feel free to register using the chat and the link. And my next announcement's a really exciting one. Please be sure to save the date for our 29th annual ITUP conference. The 2025 conference theme is going to be advancing equity, sustaining the movement from coverage to access. You can catch us all in Sacramento on February 3rd and 4th. I'm also excited to announce that we are opening registration tomorrow. So because you attended today, you will be receiving a registration link in your email. We'd love to see you in Sacramento. Please be sure to mark that date. And again, a big thank you again to all of our panelists and our audience for being here today. None of this would have been made possible though without the dedication of the ITUP team. Most of them, you're not even seeing their faces today, but they have done so much work to prepare this great event for you today. So I want to thank them personally. And again, a big thank you to our sponsor, Sierra Health Foundation, for their generous support for this event. Please use the event evaluation in the chat to tell us how it all went and share your feedback with us regarding today's policy forum. Other than that, thank you for your time, and we look forward to seeing you again on the October 29th for our next policy forum. Thank you so much.